Hello and welcome to Perry Prosthetics Continuing Education Webinar for Physical and Occupational Therapists in Ohio and Michigan. We are thrilled to have you here and appreciate your commitment to furthering your skills and working with the amputee population. Now, before we get started, let's go over the steps to receive your CEU certificate. First, please make sure to watch this video in its entirety. Once you've completed it, click the link in the description below to access the online quiz. After taking the quiz, send an email to the address provided in the description to let us know that you've completed the course. We'll then send you your certificate of completion along with a quick survey for feedback. If you have any questions about the material or the process described in any specific webinar, never hesitate to reach out to us at the same email address, or you can visit us at perryprosthetics.com. Thank you for joining us. We're excited to share this valuable information with you.
So I'm Chris Perry. I'm the founder and owner of Perry Prosthetics. I'm a certified prosthetist and a state licensed prosthetist in the state of Ohio. This QR code here will get you my contact information. I started Perry Prosthetics in the year 2000 it was just myself getting started in Perrysburg, Ohio. I had experienced a motorcycle accident when I was 16 years old, which resulted after several months in the hospital with a amputation below my knee on the right side, 83, I believe. So I went through what the rehab process was then, but the prosthetic care that I received was not as good as I would have liked it to been. I was in pain a lot and I had a really bad gait deviation, but I was also a very complicated patient. So my residual limb is less than 2 inches long below my knee, and my activity level is quite high. We might touch on some of that later. But my little brother did a science fair project, which found the top 3 guys in the world, one of them not being more than a few hours away. I made an appointment. He had a 5-year waiting list. A book was written about him, and he saw me and saw my condition of my limb and that I was young, and he moved me right in. This happened to be almost 8 years after my amputation. So I spent 8 years not knowing that there was a difference, not knowing that one place may be different than another place. I went to see him, changed my life night and day. At that time, prior to that, I was interested in prosthetics and lost interest because of my experience. Obviously, with him, I regained that interest. He hired me. I became his assistant. And from there, the rest is pretty much history. And now in 2000, I opened my own practice to bring what I learned back to this area in the Toledo, Ohio area. And since then, we've opened a satellite office in Findlay, Ohio, and one in Ann Arbor, Michigan. We like to pride ourselves on trying to involve the entire rehabilitation team. About 11 years ago, I started an organization called CARE, which is Cooperative Amputee Rehabilitation and Education. And through CARE, we provide as much education as we can to anybody on the amputee rehabilitation team. We've done cadaver clinics for surgeons, identifying 5 different surgical techniques that was adopted and developed and adopted by the Ertl family, starting way back in just post World War II, and Ertls still are practicing today, most of them orthopedic. We've done many physical therapy, OT presentations, nursing, and this is our effort to continue to reach more people. This coming year will be our 25th anniversary. We're very proud to move into that, and I'm very happy and excited. We've got a huge year planned for both patient events, our care team events. We're working more on more content for the years we move forward. So keep an eye open for that. I have a great team. I have a team of I think 14 people right now. We have accredited professionals, practitioners that are amongst the best. We are actually within my world of prosthetics. My peers are a little jealous of my team. We got a great team. So, and we adhere to some simple but very effective philosophies, but our consistent quality outcomes remain unsurpassed. No matter what we try to do to improve, better, faster, cheaper, it can never affect our outcomes unless they go up. We will not sacrifice our outcomes. I always tell everybody, if we can't get the outcomes that we are at now or better, then we need to find something else to do. Even as the healthcare changes around us, we just got to figure out a way not to let it kick our butts. So if you want to move forward, Theron.
You bet.
So the objective here today is to provide a little more in-depth understanding of limb loss, prosthetics, prosthetic rehabilitation, some of the surgical and preoperative care that we do, and then understand how the collaboration with your prosthetist can serve you. And I can't speak for all prosthetic providers, but we have put ourselves in a position to be available and to provide as much information and education as we can, because we know that to get the best outcomes, we can't do that alone. We need to do it with you. Our OTs that are attending, with our upper extremity program, we have an advanced upper extremity team here that we started about 4 years ago. Our Mike Schroeder is my lead there. He's done nothing but upper extremity prosthetics for almost 20 years, or right about 20 years. And what makes that, besides his experience and working together with my experience and building the team, what makes those outcomes so successful is that we partner hard with our OT friends. We partner with them right from the beginning. We do the same thing with PTs. And I've learned a lot from our OT and PT friends in the last 25 years. And I like to share that as well. I'm certain that one day in the future of Prosthetics, we'll have an OT and a PT on the team, not to provide those services, but to be a liaison for our OT and PT partners out in the community. So we were going to discuss some of the advancements, technological advancements, and advancements in procedures and the particular different styles of fitting the prosthesis that are new or available that drive patient outcomes. We want to kind of create a big picture for the entire rehabilitation process. One of the things that we look at ourselves as not just certified prosthetists or just a prosthetic facility, but we're prosthetic rehabilitation specialists, because we get involved with that patient from the time before they have their surgery, if we can, through the surgery, through their post-op, with their inpatient rehab, through prosthetics. We help coordinate and make sure timeframes there's no waiting in between, different appointments, that we're getting all the documentation gathered that we need to get them approved for things. And we're moving through the entire rehabilitation process with them. And then long after that, because their limbs will go through physiological changes throughout their life that will require additional prosthetics periodically. But then also this, the psychological support, the mentorship. We have people that can peer visit. I have been through amputation and have lived on both sides of the fence. We put together events. We try to motivate people at every turn. The biggest thing that we do with our patient population is turn them into experts about their own limb. We educate. Every time we see them, we want them to know as much as they can about their limb. They're informed, they know what's available, and they know how to know what they can do for themselves if they have some changes, and when it's time to get a hold of their physician or their prosthetist or their physical therapist. So we judge all that on really 4 pillars, and that's, you'll see that at the bottom of your screen. Patient safety is our number one concern, and patient satisfaction. They are at the top of the list. Just like in the fitting process, we put comfort first, and then we move into function, and then the last is aesthetics. We have an order how we do things, but patient safety, patient satisfaction, and then efficiencies. We live in a healthcare world where it's more and more challenging all the time to provide the most appropriate or the most technological advanced componentry with the way things work with insurance companies. Another reason why we partner with our healthcare team, because we can utilize each other's notes and validated testing to help with that process. So, and then our outcomes, we talked about them. Our outcomes, we set the bar very high, and we're always pushing for better. So those are the 4 pillars that we utilize as we move forward through providing prosthetic care. The timeline that we're looking at is from surgery. Sometimes we see the patient prior to surgery. We get an opportunity. The surgeon might say, "Hey, I want you to go, talk to, these people here that they're going to talk to you about what it'll be like after amputation." That's great when we have an opportunity to do that. But even if so, we still consult with them again afterwards because it's very fresh. Everything's kind of now happening. Whenever we do a consult, we always invite or let them know that we have peer visitors that would be happy to come see them. We never we don't push that. We make sure that it's by their request. We never would just send somebody in, but we make sure that it's available. We make sure that they understand kind of how important that is. Our peer visitors are trained. They don't go in and hand out prognosis. They don't diagnose anybody. They just share their experience and what they went through. Usually, it depends greatly on the protocol of the surgeon and how things go. But a lot of the surgeons we work with want these patients in compression, at least light compression right away. And then as they heal, we get into a heavier compression to get them ready for the prosthetic fitting process. Most of the surgeons we work with locally also like to have some type of a protective device, depending on that patient and the risk of their falls, so that we also provide that. We have a prosthetic evaluation that we do. We utilize, we do our own evaluation. We then incorporate physician notes and physical therapy notes. So we're always looking to get that information. Once we do our evaluation, we'll pass it along to the ordering physician with a request for prescription for a device, whether it's the surgeon or PM&R. We get their feedback after that to produce all the paperwork needed for the insurance company and get that process started as soon as possible. Our goal is to not leave any gaps in the time the patient is spending healing to the point where they're ready for prosthetic fitting through the delivery of that device and getting them into therapy. So we start the prosthetic fitting in-house. We'll talk about those stages as we move forward. We do the fitting, we do the diagnostic and alignment part of the fitting. Then we finish that device into a more permanent materials for delivery. And then we have follow-up systems that with our patients that are new amputees, we see them, we kind of make that judgment call on how soon we need to see them for their first appointment. But typically we see them about every 2 weeks after that, because their limb is going through the greatest amount of change in the first 3 to 6 months, depending on whether they're transtibial or transfemoral or even another type of amputation site. Those physiological changes need to be addressed with the socket fit so that we can keep them comfortable and keep their skin healthy, so that you therapists and the patients can continue to move forward with function and abilities and outcomes. So the follow-ups tend to move a little further apart as we're starting to see them stabilize. And then once they're stable, we move them into the definitive prosthetic fitting process, which by then the patient is using the prosthesis. They're very informed, they're very knowledgeable, and our relationship becomes much more robust as we move into that next device. And because they've seen therapists and they're out in the world and using their device, when we go to the fitting of that device, we can actually send them out to test in test sockets, where we don't do that when they're new, because they don't know what to do with them. and we want them to be more educated in that before we send them out in a test device. So, and then therapy. We, like I said, there's another potential for gap between the time we're done with the prosthesis and getting an appointment with therapy. So we start the communication early on the behalf of the patient with wherever they're going for therapy. We always refer people back to where they're coming from, unless they have a different facility they want to go to or different therapist. Or we do have some therapists that they've set themselves apart. So depending on the complexity of the patient, we might make recommendations. But for the most part, any therapist that's willing to work with us as a team is going to do fantastic, even if they've had very little prosthetic experience. And our OTs are a big example of that, with all the new myoelectric and technological advancements in upper extremity prosthetics. We definitely partner with you. We look for people that are just excited about that technology and wanting to help people, and we'll come in. We even loan some of our equipment to them to read EMGs and get biofeedback. So we definitely want to partner with you as we move forward. So, Darren?
You got it.
So we kind of went through some of these, but the pre-surgical consultation really gives us an opportunity to talk to the patient about what to expect in general. I mean, you can't guarantee anything because everybody's a unique case. But here's what generally you can expect between going into surgery, coming out of surgery. As we move forward, thanks, Darren. Appreciate it.
No problem.
We always offer the peer visitations right up until we're into the fitting process, and then if they're not interested, we don't continue to offer them. But then we have tomorrow, once a month, we have Empower Hour, which is at a local coffee shop. That it's a place where amputees of any level, whether they're new, they're veterans, whatever the case may be, they're able to come in and hang out and talk to one another and share and have questions. And then we're usually there. There's usually clinical staff there, as well as Theron. And so if there's questions, we can always jump in if it's more professional. But the dynamic has been incredible to watch. It's usually the camaraderie between the patients. It's the greatest thing that occurs there. So our follow-up system, once we see the patient and once we're called to consult, we follow up by phone every week if we did not provide anything on their limb, and just see where they're at, see what's going on, see when they're scheduled for the next step, keep them motivated, answer questions. If they were provided a light compression or protective device, we then follow up in person. We will make sure to go out to see them, and when we do those same things, we keep them motivated, answer questions, and start our education with them one-on-one, and we do that right up until they're ready to start the fitting process, and then we get going. So some of the post-operative management that we do is we'll do shrinkers or compression therapy. We have shrinker socks that we can provide that are shaped and fabricated specifically for residual limbs. The ones we use have a internal silicone border approximately that help hold on to the skin and not slide down, and they're sized according to the patient's current limb volume, circumference measurements. We have some donning aids that are available, like the donning tube you kind of see next to the gentleman in the far left picture. That's so that you can invert the shrinker sock, pull it over the tube, look at that, and slide it onto their limb without pulling on the incision site. This can be done with the shrinker sock. We also use a compresso tube stockinette. It can be done with the first layer, but not the second layer, because with that stockinette, you put on the first layer, there's a plastic ring that slides up, so it's up against the distal end of the limb, and then you refract the second layer over. The biggest thing to remember with the shrinker socks or compression stockinette is that the distal end needs to be up snug against their limb. Some of the other things that we do post-operatively, he'll probably have this picture back up before we know it, is the Rook. The Rook is a post-operative device that's helps keep their knee from becoming contracted. We don't have one for transfemoral, but for the transtibial, it's kind of a light compression or a light protection. It's not going to help greatly with a direct fall. If a patient is thought to be a higher risk than average, we do what's called an RRD, which we just call that's our rigid removable dressing. But that is a clamshell device that's custom fabricated over their limb. We turn those around 24 hours. Some of our surgeons make that judgment call right from the beginning, and they get ordered right away. And then we go out and do the education on that. We do education on this as well. There are QR codes and videos on all this that are available that explain the donning and doffing process. Limb wrapping, obviously, the figure 8 kind of wrapping techniques. We go out and do a lot of this education. I always get kind of big props for my wrapping technique. I've been doing this since I was 16 because I was wrapping my own limb. So I've really got it down. And I talk about, how much compression to take out. I have kind of my first part is just get the distal end coverage. Once you got that good coverage, when you come over right there, I'm taking 50% of the stretch out of the material. As I go around behind their limb, I'm only taking the wrinkles out. I don't want it tight behind the limb. And then as I come back down and go around their limb again, distally, I take out 50% of the stretch. And that's my pattern all the way up. No stretch, don't take out any of the stretch coming around behind their limb, just enough to get the wrinkles out. And then stretch it as you go down around your distal contouring. So this can be very challenging. It works pretty well with transtibials. You get into transfemorals, and really, I like for light compression, I'd rather put them in a shrinker sock and size it up because those silicone dots on the inside help hold it on. If you try to wrap a transfemoral patient, my guess is within minutes of after having it wrapped, doing bed mobility or moving around, it's going to come undone. And when they're undone, they can cause, or they slide, they can cause like a banding of rubber band effect. And that's going to increase pain. It's going to block circulation. And it's really doing everything we don't want it to do. So I always recommend not even wrapping a transfemoral patient. If they're not quite ready for a shrinker sock or a increased size shrinker sock, then we wait and give it the couple days or a week that it needs, then get them into a shrinker sock. Better that than to have an elastic wrap around them improperly not because it was put on that way, but because they moved and it slid down and created some issues. So Theron, we can move on to the next slide. So when they come on site for our evaluation, we obviously inspect the wound and sutures. One of the benefits of being, part of the team and building robust relationships, we see that patient every week to make sure, if we put them in something, to make sure everything is going fine. If not, we call them and we talk about how things are going. It's amazing how many people will have something happening with their wound that won't bring it up or won't go out of their way to call the surgeon to move up their appointment. But when we see it, if we see them or we're talking to them, we ask about it. If it sounds like it could lead to an adverse event, we get a hold of the surgeon. We move up the appointment. We can, identify the drainage and stage the wound. We can talk to the surgeon. I've had surgeons actually call in antibiotics based on our conversation and then have the patient come that day or the next day, if they can. So it really helps with the outcomes and the efficiencies to reduce the chances of adverse events because we're an extra set of eyes. And we don't charge for these appointments because in prosthetics, we only charge for what we provide. Prosthetics provides these appointments because we think it's thorough and the right way to get the best outcomes. So those inner procedural appointments that we do are because that's the right way to do it. That's how we feel. So So we're always a team player for not only the patient, but for the whole healthcare team. If we see something that needs to be addressed in therapy, and the same thing, we built some great therapy relationships with therapists. They know when the patient's coming, they'll send a fax or they'll text me, say, hey, will you look at this? Or the height doesn't seem right anymore. Because these patients are changing, their limb volume's changing, their height can potentially change, and making it difficult to, for proper gait or for a sore back. Or we welcome all the feedback, all the team, anything team related that's going to help that patient, we're in. We cover the patient history. We look at what they're doing for work or what their recreational habits are, their ADLs, their goals, their aspirations. And we take that into consideration as we build the treatment plan and prepare the insurance paperwork, which has become quite a process. Anybody that does private practice or is involved with the billing knows how arduous that has become. We use ProApp. We constantly are checking our outcome measures, not only to determine their K levels, and so not only to determine their K levels, but to know where they're at and see how they've progressed. We use validated testing. We use AMP Pro and AMP No Pro, which is validated specifically for determining an amputee's potential functional outcome. We do timed up and go, 2-minute walk test. We do several self-report tests. We do them at intervals throughout we do it in the beginning. We do it at just after delivery. I believe we do it at 3 months, 6 months, so and so on. So we have a really good measurement of how the patients are doing and how they continue to do. And if you're measuring it, you can fix it. So if you see things that look out of the ordinary, we can go back and look at our process. We can look at our treatment plan philosophies. We are kindly too. We are constantly improving our process. So let's go ahead and move forward there. We just talked about the K levels. K levels, unfortunately, us amputees are clumped into a category. Those categories help determine what we get technologically. It's I don't like it. There has been some very recent changes that have made it a little better, but these are the categories: K0 through K4. K0 is pretty much they don't have the ability or potential to ambulate or even transfer safely. It's a very low level, most of the time a non-prosthetic candidate. What we do is for those people that fall into that category, because the human will is so strong of a force and the body is an amazing machine, that we give them some goals to reach. We give them some, goals to reach, what they have, need to achieve, and then some of the modalities to help them get there. And we share that with the therapist as well. And if they get there, then they're a K1. Now we can get them into something where they can stand, they can walk on controlled surfaces. So a K1 is just that, somebody that can use a prosthesis for standing, transfers, walking on a controlled surface at a single speed, with or without an assistive device, or with an assistive device, typically in this case. The next K level is a little different. They can do, again, it may be with or without an assistive device as a K2, but again, we're at a single speed, a single cadence, and they are able to negotiate some environmental barriers, low-level barriers. The biggest difference between K2 and K3, because you can be K3 and still have an assistive device, the difference is that you're still negotiating some environmental barriers, whether they're low level or even a little more challenging, but you have the ability to vary your cadence. And that's part of our testing. So they're able to change from one speed to the other. And that doesn't mean they're taking bigger steps. That means their stride speed is actually changing. And K3 level amputees have access to the majority of the componentry that's available. Some of the K2 level, some of the componentry that's available would actually help K2 level patients become K3 level patients. So it's kind of unfortunate that sometimes they can't get into it. But determining the K level for us as prosthetists also includes what we professionally feel subjectively that that the patient will be able to achieve their potential. So they give us some leeway in determining the patient's potential K level. But if we provide all those validated studies and they're solid mid K2, it's going to be hard for us to do that. But if they're toward the higher range of K2 and we feel that with the appropriate componentry, it may make the difference to get them into a K3, we will go that route to get them what's the best technology available for them. And then a K4 is somebody that does high impact running, competitive sports. I'm a rock climber. I scuba dive. I hike like for days on end. So I would be considered a K4, even though I'm not in competition. I can do a 5K. I'm just starting to train for my first half marathon because of some advancements that I made in my technology. I think that although I'm 57, that this is my opportunity. It's now or never. So I'm going to try that. So we, as a K4, pretty much have access to anything that's out there. That doesn't mean our payer source is going to cover it because that's dependent on every payer source and every policy. But all these K levels were determined by Medicare. So for Medicare, if you're a K4, they're going to provide pretty much anything that's available. K3 is a really high range of things. So we don't write the orders. We can't. The order itself has to come from a physician. Most physicians rely on us to put together the treatment plan and determine what would be needed. And sometimes throughout the process or fitting process with a patient, we may see some deviation from what we originally thought was the most appropriate. We can make those changes. We can work those changes into a change in order with both the physician and with the payer source. So, but the necessary documentation, we've started using PM&R more than it used to be used when I started back in the Stone Age. So the PM&R, they are set up for evaluating the big picture and focusing on the obstacles, and their notes are impeccable when it comes to submitting them to get things approved. So we've talked to, because a lot of our surgeons like to work with us directly, and and some of them want to stay in the game, and I am glad that they are that way. But I let them know that your time, this paperwork, that it's intensive, and your time may be better utilized in another area. We can keep you in the game, though. We send them videos and how patients are doing and progress notes, and we try to get the PM&R more involved, and the PM&R teams love it. And then you work with PM&R, so we do that quite a bit now. So upper extremity prosthetics have no K level. That's all for that's all for lower extremity, and then lower extremity bilateral patients also do not have to fall into a K level. However, we do have a validated testing platform for bilaterals to help kind of determine where their functional outcome is based on a score that is related to a K level. The nice thing about that software that I'm talking about we use, and we can share that with our PT friends, is that the software itself is also kind of a point of care system. So once that patient's scored on each individual category, it will put together kind of a summary and a recommendation on what areas of work can be done to bring that patient up to the next level. And that software and that validated test was designed by Bob Gailey out of Miami University. He's a full professor there at the Miller School of Medicine, and he's really considered to be the guru of physical therapy in the amputee world all around the globe. And I'm going to throw this out there for year 2020 or our 25th year. We've been in talks with Bob about coming in and doing an on-site live CEU course, which is either we've done them in the past. We've done a 2-day course, and we've done, I think, a half-a-day course, but they are phenomenal. So keep your eyes open for that as well. We can move on.
Absolutely.
So why all the paperwork? Well, I mean, just like anything else in all of our other healthcare fields, paperwork has become quite the obstacle. But in prosthetics in particular, back in 2011, there was a Dear Physician letter written to the doctors, and it said prosthetics on the top. So all those surgeons just threw it in the trash because they don't do prosthetics. But what it said under that was, if your notes do not include the following things, which was a big list of things, then the prosthetic provider is not going to get paid for what he provides, or she or they, which they started enforcing in 2012, September of 2012. I know exactly when it was because it brought prosthetics to a halt across the country. I jumped on that bandwagon very quickly. And because I was at a convention or in one of our professional meetings prior to that, and I listened to a gentleman talk by the name of Dave McGill, and he owned a prosthetic facility. He's an attorney. He's an administrative person for a very big company. He was on top of some of these things, and just what his presentation was on, I was like, wow, all that makes sense. Let's get some validated information in these patients' charts. And because I did that and adopted that, the damage to my business was really slight compared to, 17% of the businesses my size in an 8-state area either shut their doors, sold out, or went out of business. So it was very significant. So ever since then, it took even Medicare, it took them until the spring of the following year to be able to tell us what all they needed because they didn't even know. So I've got my own reasons and theories of why all that went down, but what's important is that it did, and we need to now maintain this documentation now to even get the process approved, where before it was just to get paid for after we got it done. Now that's pre-authorized through Medicare. So that's the biggest reason. All the documentation has to be provided. I mean, your notes and our notes are part of the medical record, which is so we can provide some really important stuff to the physician and they can get it in their notes. They are now responsible for a little less, and that's why we use PM&R, because our notes and your notes provide a bigger picture as to potential and where they're at functionally and physically, and with regard to the amputation or the disability that we're working with. So we can move forward.
You got it.
How am I doing on time?
You're doing fantastic.
All right. So the importance of physical therapy and occupational therapy. I don't even really have to get into this because you all are physical therapists and occupational therapists, and you know you're the most important people in the world because you do such a great job. I couldn't imagine doing prosthetics the way it's done in so many facilities across the country where they hardly even talk to their therapists or there's no interaction. We have significant interaction. You'll see two therapists in these pictures that are local. The one on the left does a lot of lower extremity. She's got so much experience that she can look at a prosthetic component and know the characteristics of that particular component, what it does, what it's looking for, and how it affects the patient's gait. And by whether it's working properly or not, knowing what the patient's doing. That's pretty significant in the PT world. That takes a little time. So she's gone out of her way to go to do more like the Bob Gailey courses and anything that's been available prosthetically. She jumps on that bandwagon. If we have something going on, we always let her know. because we've worked together for 25 years, and have had some really great results. Even with the stuff like hip amputation and hemipelvectomies, which you will see very few of. However, I've done over 20 of them. They tell you in prosthetic school, if you do 3 in your career, 3 or 4, it's a lot. She's very proficient at that as well, just because of the amount of work we've done together. Anybody in our area, anybody that's interested in partnering like that, we're open to that. She has a lot of experience, and she is happy to share or talk to any one of you. She's made that. She's made sure that we know that. And then there's some other therapists that we know and have worked with that have very, very good and very consistent outcomes. They're willing to share as well. This is an OT on the right with one of our patients. So we work together. That's Mike Shorter in the background. He is our upper extremity specialist. This particular patient is a shoulder amputation and had TMR, which is targeted muscle reinnervation. And they're doing some testing and some training to control those EMG sites to operate a full prosthesis. So it kind of goes without saying, you can't just not work together on something that's that extensive and that technologically advanced. You can't just work separate. I mean, you have to work together. So we love you guys. We're going to keep loving you guys, and feel free to contact us anytime for anything. Go ahead, Mike, Theron.
Yeah.
So the fitting process, obviously, our goal is to get a comfortable, well-fitting prosthesis that is by far, firstly, comfortable and then functional. So that a lot of people are like, why, somebody comes to us with a prosthesis from somewhere else, and we can make some adjustments to try to get them by, but many times doing adjustments after you've already poured the foundation is very difficult to get good results. But we have had some success. The basic socket design, though, dictates a lot of what you can do after that. So we are always constantly investing and involved with new socket design techniques. We try them out. We don't just throw them on a patient that's next in line. We actually pick patients that we have that are already veteran patients. They know they may have been fit in a few different designs, but they know what to expect. And then we say, hey, would you want to be I like to call it an examputee for us, so that we can try this new process and get good feedback. And we've invested quite a bit in that. So we're constantly improving this. It is the foundation of all outcomes, is how comfortable that leg is when you're standing on it, how much time you can put on it, whether it's causing nerve pain or discomfort. This is, I don't care if it's whittled out of wood, made in on a computer, or fabricated through a liquid laminate. No matter how it's done, it has to be comfortable, and it has to support the body. And it's first comfortable statically and then dynamically. So go ahead, you can move forward. We've worked with a lot of the big manufacturers. We've done FDA trials with them. I'm on the board of advisors for one of I think it's like the second largest company in the world. And it has its perks, because the foot I'm walking on, I've been walking on it well before it was available to the world. And it is now available as of September, and it's, a fantastic device, piece of equipment, technology, however you want to put it. I love getting feedback. I've tried a few things, but I prefer doing it with my patients. And we usually have access to things early enough to try it and see how it works, to help give feedback to the manufacturers, as well as, knowing what to expect is going to be available for our patients. So that was kind of a sidebar. Back to the fitting process. We do diagnostic fitting sockets. Typically, they call that a test socket. They're typically clear, so we can see through them. We can change the shape and make adjustments to them easier than when we get the finished materials. They if we need only one, that's great. That's very rare. We're getting to the point where we can typically get somewhere in two. If somebody's more complicated, we'll do as many as we need to. Insurance companies pay for two. I've done 14. So we do what's needed to get the end result. Fortunately, we get there more often than not in the two, maybe three, and we don't have to do 14 all the time because I may be doing something else. That might not work so well for a business plan. But we do what it takes to get the patient comfortable. Once we have the socket, we then attach the components to that and work with the alignment, all the different angles of the prosthesis and rotation and height to get a good. So we start gait training with our new amputees because we need to have some to get the prosthesis ready to come to you. We want it to function well enough that you've got a starting point and that the patient's comfortable enough to bear weight on it. They can transfer their shift their weight, progress from heel to strike to toe off with hip progression, and everything's working fine. The leg's not coming off. It's not rotating. We try to send, we know your time is valuable. We know your time is limited. We want to get you what we don't want to slow you down by having things not be ready. Again, is a good reason why if you see something, don't hesitate to say, hey, I was working with this patient and the leg rotated for 45 degrees. My guess is that's not going to happen with us, but if it does, let us know.
Right.
So the delivery appointment is, we kind of go over everything, that recap, make sure you can don and doff it, make sure that you're comfortable, everything's fitting well. We talk about, we've already educated so much to this point, but we'll talk more about how they can manage their sock ply and adjust for volume changes throughout the day or as time goes on. We make sure that they know what their wearing schedule is. We rely on our therapist to let them know during that wearing schedule, this is what you can do functionally. And then we increase the wearing schedule fairly quick. But the function is we leave that to you. You're the experts in that area. We just want to make sure that they're not overusing the prosthesis. We don't want to cause any setbacks because they tried to go too quick. Our wearing schedules aren't the same across the board. We determine our wearing schedule for each individual, their limb, their compliance, and we move them as fast as we can forward without putting them in any danger of being set back. So our follow-ups are basically when they're new every 2 weeks. We might bring them in sooner depending on how we feel they are with their knowledge and understanding. We might bring them in the first time in a week, but about every 2 weeks, we're seeing enough change and volume changes in the limb that we need to, that they can no longer manage it with sock ply, and we need to make changes in the socket. Once we see that they're becoming more stable, we'll bring it out to 3 weeks. And then once they're stabilized and we see very little changes, it's time to refit them with their definitive prosthesis and utilize all that experience they have to be a better team member and everything that they've learned from you, because now they're probably discharged from therapy and at the end of this initial prosthesis, and they're out doing things out in their life. And we start testing that definitive leg outside of our bars, outside of our office, in their activities of daily living. Our goal is to make sure that a patient is getting at least a week, if not 2 weeks, worth of full activities of daily living in the test socket before we move forward and make it a laminated carbon fiber socket. Go ahead, Tim. Some of the setbacks. Yes. What's that?
Nope, you're good.
Okay. Some of the setbacks we see, falls are a big one. If the limb breaks open, if it doesn't break open, they still get some swelling and bruising. We have to wait for that. Healing issues. Obviously, everybody has, they're an amputee for a different reason, and there could be other outside factors that influence healing. Their hygiene habits, their compliance to dressing changes, their physiology. So those things can cause setbacks. We try to fight those with education, and then we see them weekly. So that's the other thing. We want to keep our eyes on them as much as we can, or talk to them as frequently as we can, getting them through to the fitting process and then beyond. Comorbidities obviously can be a setback. If they have multiple things going on, some of the patients we work with are in the middle of having other surgeries and other, other deficits that need to be addressed that take a priority. But we all have that. We've all come across that. So next one is questions, I believe.
You got it.
Are you able to open up questions? Do we have time for them?
Absolutely. So, folks, what I always do, and thank you again for your patience with my Wi-Fi struggles, but I think I'm good now. If you have to bail, you're good to go. I know people have patients to get to, so no problem. You can log off, and you will be accounted for. But I am going to open up to questions just for 5 more minutes.
So we have asked one.
Yes. Can you read that, or you want me to read it to you, bud?
Well, they asked if, just to be clear, if we start with a clear plastic test socket right after the incision heals. No, once the incision heals, we want to put them in a stronger compression for at least 10 to 14 days to help shape that limb. Then we cast them or scan them. We do a digital scan or a cast, and then utilize that model to build the first test socket. So from the time they heal to the time they're standing first time is usually about two weeks, maybe 3. But usually from the time of them healing and us getting the thumbs up, from the time of the amputation to the time of them getting a device and beginning therapy is usually about 8 weeks total. Okay. Sometimes 7. And then longer if we hit delays.
And then and specifically post-op, when are you using shrinkers versus wrapping?
Well, we really like to talk to the doctors about that. So that's kind of by order. Some doctors don't like using the shrinker socks because it pulls on the incision site. But with those donning tubes and done properly, especially if it's light compression, so we're sizing it up to get that initial light compression that still is very effective. If we can talk to the doctor and explain that to them, a lot of times, almost all the time, they give us a thumbs up. And that can be, we're called, the doctors that do it now, that like us to do it, they're calling us out the day of amputation, typically, or the day after. And we're getting that patient in light compression right away.
And I think we'll call this our last question. Do you visit nursing home patients, or do they come to us?
So it all depends. So yes, we do go to nursing homes. It's counterproductive depending on what we're providing, because we do everything in-house. We have a full lab that we cannot bring with us. So we can only do like little pieces at a time if we're coming there. If there's transportation available, that's the best thing to do because we can get so much more done. But for like initial consultations and talking to somebody, we would definitely come nursing home. For delivery, to work with the PTs at the nursing home, like, hey, here's the device. This is where we're at. This is what we're used. This is why we use it. This is how it's being fit. Boom. We hand the torch to you. We talk together with the patient right there in your gym. We do that. We will do that anytime that we're asked. So sometimes scheduling, we got to get it scheduled, but we're usually able to get it scheduled pretty quick.
Perfect. All right. Again, if you need to bounce, no problem. There was one more question. I think it's a good one. When is a good time to refer the patient to a prosthetist for recent post-op? I'm assuming it's care.
Well, we don't want it. So if we're not working with team members that we work with on a regular basis, because that's pretty streamlined with the people we work with on a regular basis. A lot of times it's skilled nursing. People fall through the cracks. We have a meeting every Monday morning that we follow to keep people from falling through the cracks, but that's not always what happens. So is that limb, if they've had surgery, and even if they still have sutures in and they have not had a prosthetic consult, it's time, because they need to have somebody come out and talk to them about the process, what to expect, to make sure that's something that they want to engage in. Give them a realistic prognosis of what, with a device, what they would be able to do and how soon. And then we can monitor when it's time to actually physically get started. If somebody's there and they have an amputation and they have sutures, we want to, if the doctor didn't order it, we'll contact the doctor and say, hey, we were asked to see this patient. This is where they're at. This is what we would like to do. Are you in agreement? Do you have any questions? Do you have any concerns? Can we move forward? So a lot of times we can help get the ball rolling as far as the orders to your facility. So if they're an amputee and they have not been seen by anybody, or it's not moving forward for some reason, please feel free to give us a call. We always do evals and consultations at no charge. Remember, everything we do is charged only by what we provide. So the time we spend visiting and educating or doing pre-op or post-operative consultations, there's no billing to that. There's no strings connected to that. If somebody's seen another prosthetist and we think that what's happening is just a little delayed, but they're on the right steps, we're just going to refer them to get back to that process. I've been known to even call and say, hey, I just want to let you know we were reached by, we won't say who, somebody to see this patient. It looks like you're doing a great job, but it looks like they're ready to continue. Sometimes they just need a little bump, or maybe it fell through their cracks. But if we see something that we think you'd be better off somewhere else, we're going to tell you. So that's my I went through terrible prosthetics for 8 years. I'm not letting anybody do that. So.
Okay. All right. Well, again, thank you guys so much. We appreciate you guys joining us again.